Good morning, everyone.
Good morning.
Good morning.
Good
Good
morning.
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 Good morning.
Good morning.
Good morning. Everybody was able to scan the QR code?
Yes.
You. See the course key. Okay, there are a few students showing absent. Nathan, Soren. Okay, last name Sham. There's 3 students showing absent. Anybody aware about anybody experiencing any issues? No? You guys have a group chat, right? You have a group. Could someone please drop a text if anybody experiencing any technical difficulties?
He's having issues with his computer, Soren.
Yeah.
So, okay. Okay. Excuse me. You guys have any questions before we start the lecture?
I do have a question. At some point today, can you go over kind of like what med questions might be on Friday's test? Besides like the basic ones that we saw on ATI, is there going to be like IV drip rate and stuff like that?
Yes. The calculations, yes.
Okay.
There will be pretty much all your weekly exams as well as final. They will have calculations.
Okay.
Are you going to give us some of the conversions or no?
Are you talking in the questions like conversions from one unit to another?
Yes.
Yeah, calculations, it could be anything. Unit conversions or calculating the dosage or it just it's not that certain type of calculations in exam 1 or 2 or 3. It's not, they're all mixed up.
I think the question is, are you able to go over some examples of these questions just so that we're familiar with them?
Okay. Um, as
If
I
time
just
permits.
mentioned, so let me just say that again. I have no problem going on some, but again, it's not any specific type that it's gonna be on this exam. So which one do you want me to go over? Is there any particular ones you are having trouble with? Because I cannot
IV drip
narrow
rate
down.
would be a good one.
Average rate? Yeah, we can
Mhm.
go over some. That's not a problem.
Will there be a calculator provided like in the ATI browser, or do we have to do manual
It will be on the
calculations?
ATI. Yeah, ATI screen, you will have that.
Professor, do we bring our computer or they gonna provide their computer?
Or we're gonna use the school one?
Um, Usually, it's the school computer.
Mhm.
I would say just for backup in case you want to take it, go ahead. But usually it's the school.
So I want to just know a little more details. It's gonna be, we're gonna log into our ATI and then the exam is gonna appear on our screen. That's how we're gonna take it, or? We're
That
gonna
is
be given
100%
a,
correct.
oh yeah, are we gonna be given like a product code or anything the day of?
No.
Okay. So we just need to know our login and then password to be able to use the
Yeah,
school.
just all you gotta do is log into your ATI account, and then they will give you the name of the exam. So under assessments, you'll go and find that exam and keep moving until it stops you and say like, you know, Proctor is unavailable or Proctor will approve you. Just keep moving, and then once whoever's proctoring there, they should be able to approve you.
Is it like proctor? It's gonna be person inside a room, or it's like in a computer?
Yeah. No, or in the room.
Oh, so the name of
They will
exam.
approve. No, they will approve on computer, their computer, but there
Mhm.
will be somebody physically present there as well.
So the proctor is physically present. It's not through the computer.
You
So,
will be going to campus and
Mhm.
somebody physically be present there to proctor. But when you log in, so somebody from their computer, they have to approve your exam on their computer.
Who there? Sorry.
Whoever the
What is it?
instructor is that day.
Oh.
Whoever is there,
Mhm.
whoever is there.
Mhm.
That part I'm not aware about who will be because I don't go to campus, so I'm not sure how they're managing, but somebody should be there.
And what's our name of the exam will be? Is it chapter
Yeah,
1, 2?
they will provide you that. It'll be exam one, but it will say pharmacology exam one, but before that you will see like your cohort name as well. Okay.
Thank
That
you.
will be provided to the proctor, so that should not be a problem. You will have that name. Okay, no worries.
So if we have any question, we can ask the proctor.
Absolutely.
Thank you.
Mhm.
Will there be anything from week 2 on it, Professor? Or just
Okay.
one?
Just week one. So exam one is based on week one, then your exam two will be based on week two, and so on.
Okay, perfect. Thank you.
You're very welcome.
And it's a 60 questions, right?
Yes.
It's
All your weekly exams are 60 questions, and you will have 1 minute to answer each question. Technically, a total of 60 minutes, right? And then your final exam is 80 questions and a total of 80 minutes. Okay, any other question before we start? No? Yeah, we're still missing Nathan. All right, so let's start the lecture, guys. Excuse me. Okay. Okay, so as we covered 4 chapters yesterday, so we'll be covering 4 more in today's lecture. So first one is your adrenergic drugs, okay? Adrenergic. As I mentioned yesterday as well, try to know the concept. Okay? Try to know the concept, the reason behind it, what the problem is, and how are we fixing it. And some chapters are completely kind of, mirror image of the other, completely opposite. Like if you are doing adrenergic, anti-adrenergic are completely opposite. If you're doing cholinergic, anticholinergics are going to be completely opposite. So if you know one, well, you pretty much know the other side. Uh, applying the simple concept of thinking in the opposite direction. Okay. So we'll talk about your nervous system, um, and then we'll talk about some common conditions and common drugs used, um, and similar information like any adverse effect, interactions, as well as important aspect of nursing care plan. Okay, so first of all, nervous system. So nervous system is a complex network which is responsible for coordinating all activities within the body. So if we divide it into two branches, one is the central nervous system, the second is your peripheral nervous system, okay? CNS and PNS. Now, first of all, your CNS, let's divide it into two, which is your brain and spinal cord. The brain is like your computer CPU. It controls the thought process, emotions, movement, and several other functions of the body. Has multiple, different parts like cerebrum, cerebellum, brainstem, and then spinal cord. Think like, in our homes, inside the walls, we cannot see it from outside, but you know how there's electrical wires running through the walls? We have the conduits and we have those electrical wires which send and receive the signals, right? So similarly, your spinal cord has bundle of nerves which transmit the signals between the brain and rest of the body. And that is why when if somebody has like a severe back injury, that transmission is start getting messy there. Um, Now, as far as the functions, brain, we know the processing, interpreting, including the spinal cord. So that's a part of that information processing or transmitting, and then sending the commands to the body, like reflexes, movement, and then cognitive functions such as memory, attention, problem solving. On the other hand, the peripheral nervous system (PNS). It is also divided into motor and sensory neurons. So your sensory neurons are technically just the senses we have, right? Which were hearing, vision, taste, all those. And motor is to do with doings, okay? So it connects the CNS to the muscle and the glands. It is further divided into two parts, your SNS and ANS. SNS is your somatic nervous system, which controls the voluntary muscle movement. Voluntary muscle movement. Involuntary, which are happening on its own. Okay, such as your heartbeat. You don't control it. It's automatic. Digestion. You don't press a button and start the digestion process. That's on automatic. Now, your ANS, autonomic nervous system, further divided into two branches, sympathetic and parasympathetic. Your sympathetic nervous system is fight or flight in case of fear, danger. Should I stay or run away? That's fight or flight. That's sympathetic nervous system. And then parasympathetic is rest and digest functions. Okay. All right. So moving from here, as we just talk briefly about CNS, the central nervous system, which consists of your brain and spinal cord. Once again, what is the job? Processing and interpreting sensory information from the body and then coordinating the responses. What does it control? Like here, body movement, sensation, thoughts, emotions, reflexes, controlled by your central nervous system. Divided into two, brain, spinal cord. So those signals in the PNS as well, the signal goes in both ways. Okay, one are coming in, the other are going out. So there are two different type of nerves involved. Afferent, which starts with A, and efferent, which starts with E. The difference between them is afferent nerves, they transmit signals to the spinal cord and brain. Now, based on that, brain, okay, or you can see CNS, it is now sending the signal to the body parts, and those are carried by efferent. Afferent and efferent. One brings signal to the brain, the other one from the brain. Okay. And your somatic nervous system controls the voluntary and autonomic, involuntary, which are happening on its own, such as your heartbeat and all that. Okay. Now, as far as neurons, what are those? What is synapse and what are neurotransmitters? So neurotransmitter are just the chemicals like your epi, norepi, acetylcholine, serotonin, dopamine. They're called neurotransmitters. They are the chemical messengers. As far as neurons are the basic building blocks of your nervous system, and they're specialized cells which transmit electrical as well as chemical signals throughout the body. And then each neuron itself consists of a cell body and has dendrites, which receive the signals, and an axon, which sends the signals. And synapse is a junction between two neurons. So it's one neuron, other neuron, and the junction in between them that is called synapse. So whenever an electrical signal reaches the end of an axon, it triggers the release of chemical messengers that crosses the synapse to the next neuron and so on. I'm going to show you a short video, and that might give you a little visual regarding what we're talking about.
At Honest, we know that touch is your baby's first love language.
Imagine yourself in the middle of a game of catch. A player throws the ball towards you, and as the ball jets closer, you quickly recognize where to position your hand in order to catch the ball safely. Have you ever wondered how your brain is able to so quickly make that decision? How does information flow so fast from your eyes to your brain and back to your hand in order to successfully catch the ball? All information from our environment, in this case, information from the eye about the size and speed of the ball coming towards you, is converted by nerve cells or neurons into electrical signals that are carried to the brain. Similarly, information from our brain to our body, such as an order to move our hand towards the ball's trajectory, is also sent in the form of these signals. These electric signals are called action potentials or nerve impulses. Because these signals are instantaneous, our brain is able to help us quickly detect and respond to things in our environment, both good and bad. It is thanks to the speedy nature of such signals that you can immediately recognize your favorite song, or quickly pull your foot away when you step on a pin. So how do neurons send these signals, or fire these action potentials? The human brain contains tens of billions of neurons that are connected to each other. Each neuron has a cell body with several branches. The smaller branches, called dendrites, receive signals that come together, and then the total signal is transmitted through the longest branch, the axon. Similar to how a wire carries electricity from a switch to an electric bulb, the axon carries nerve impulses from a cell body to the next cell. The outer or extracellular surface of a neuron is bathed in a salty solution of positively charged sodium and negatively charged chloride ions. The inner surface has a positively charged potassium ions and proteins that are negatively charged. The negatively charged proteins inside the cell are not balanced by an equal number of positive ions, making the inner surface of the neuron slightly more negative than the outside. This gives rise to an electrical gradient. Furthermore, there is a higher concentration of potassium ions inside, giving rise to a diffusion gradient that forces them to flow outside. Thus, there is both an electrical gradient and a chemical gradient, an electrochemical gradient, forcing ions from inside the cell to go out. Each neuron, when at rest, maintains a voltage difference arising from the electrochemical gradient, just as a battery maintains a certain voltage between its poles. This voltage of approximately -70 millivolts is referred to as the resting potential of a neuron. The cell membrane of the neuron contains ion channels. These are pores formed using proteins that selectively allow certain ions to pass through, similar to how an airport security guard checks visitors and only allows those with a ticket to proceed to their gates. Some of these channels are special in that they open and close only at a certain voltage. These are called voltage-gated ion channels. Ion channels allow ions in and out, causing the voltage of the cell to move away from its resting potential. At any given time, a neuron keeps receiving small amounts of incoming signals, which results in small fluctuations in the membrane voltage. These are called graded potential, but they are not strong enough to result in the firing of a neuron. A neuron fires or generates a nerve impulse only when the total sum of input signals is large enough to cross a threshold potential of -55 millivolts. This begins because it triggers voltage-gated sodium channels to open. These channels, when opened, cause a rush of many sodium ions into the cell from outside. This causes depolarization of the neuron, or a reversal of charge in its inner surface from negative to positive. The voltage difference continues to become more positive. When the voltage reaches 30 millivolts, it causes voltage-gated potassium channels to open. These channels allow potassium ions to move from inside to outside, slowly repolarizing the cell or restoring the more negative voltage difference. However, the voltage-gated potassium ion channels are much slower to close, causing the voltage to drop below the resting potential of -70 millivolts. This is called hyperpolarization. After a neuron fires in this way, its voltage would be drained, like a rechargeable battery after prolonged use. A reusable battery, however, can be recharged by passing an external current through it. The neurons outsource this job to pumps located on the membrane by spending energy currency called ATP. These pumps act like revolving doors in buildings. They let out more sodium ions from inside the cell, while simultaneously bringing in fewer potassium ions. This brings the neuron back to its resting potential. This entire event of neuron firing follows certain rules. 1. It is an all or nothing event. Nerve impulses are much like digital signals. They occur in the same magnitude, regardless of how strong or weak the stimulus is. However, the threshold voltage must be crossed in order to generate it. 2. They are unidirectional. Once a segment of the membrane becomes depolarized, it passes the signal forward to the next segment. Ion channels, after finishing their job of passing the signal, will pull down their shutters and take a break, becoming inactive for a short while. This is called their refractory period. Therefore, a signal cannot return to them and has no choice but to travel forward to the next segment on the membrane. The process of generating a nerve impulse is fairly quick. However, in certain situations where this is not fast enough, our body uses special neurons with a coating called a myelin sheath to speed up signaling. This coating covers the surface of the axon while leaving small spots called nodes of Ranvier open. In such covered axons, the signal doesn't have to travel through the entire length of the axon, but only through these gaps, making the signal travel even faster. This type of jumpy signal transmission is called saltatory conduction. In our sense organs, these nerve impulses are caused in response to a sensation, such as odor, taste, touch, sound, or light. For example, in the eye, a nerve impulse is generated in response to light reaching the cells of the retina, which are then passed on through the optic nerve to the part of the brain that processes visual information. The nerve impulse can also have a variety of effects based on where it is sent. When you accidentally step on a pin on the ground, nerves in the spinal cord respond by sending a nerve impulse to your leg muscles, asking them to contract, thereby pulling your leg away from the pin in a fraction of a second. The brain constantly makes sense of the pattern, frequency, and area of origin of the incoming nerve impulses in order to interpret them, and then responds by making appropriate commands to the relevant body parts. In a way,
Okay, hope you were able to kind of understand
impulses-
a little different way, because some students are visual learners. Let's move on now further. The neurotransmitter or the chemicals, the messengers, they are acetylcholine, appy, norappy, dopamine, GABA. All these are your neurotransmitters or chemicals. As far as your sympathetic, parasympathetic, once again, the sympathetic nervous system, it activates the fight or flight response, preparing the body for stressful or emergency situation. It increases the heart rate, dilate pupil, and then release adrenaline, getting the body ready for action. On the other hand, the parasympathetic nervous system, it promotes the rest and digest response, then helping the body to relax and conserve energy. It slows down the heart rate, stimulates digestion, and helps with recovery and maintenance during calm, non-stressful conditions. We to move on to next. Okay, now let's talk about some problems and the drugs. So adrenergic drugs, what are those? How they help your patient? Adrenergic drugs are the medications that stimulate the adrenergic receptors in the body. They mimic the effect of the sympathetic nervous system, which is responsible for fight and flight response. So these drugs, they act by either enhancing the release of your appy and norappy, which sometimes we call it as adrenaline, or directly stimulating the receptors itself, the adrenergic receptors. Now, the type of adrenergic drugs, they are also called sympathomimetics, that they mimic the effect. Or you can call them adrenergic agonist. It could be direct acting, indirect acting, or with mixed action. So direct acting, they act directly on the receptors. They're your appy, norappy, dopamine. Indirect acting, they increase the release of norappy, and then that's what causes the response. And mixed acting, they can do a little bit of both. Okay. Now, when we talk about these drugs, there's certain receptors you're targeting, either alpha or beta. Now, alpha is also subdivided into two categories, alpha 1 and alpha 2. Similarly, beta receptors are also further divided into two, beta 1 and beta 2. If the drug is alpha 1 agonist, it is going to increase the blood pressure. Okay. And if it's an antagonist, it is going to decrease. Right? So alpha 2 agonist, they are usually used to lower the blood pressure, such as your clonidine. Then beta 1, beta 2. Beta 1 belongs to the one organ in the body, heart. Beta 2 belongs to two organs, lungs. Okay, that's where the action is. Beta 1, they act on heart, and then beta 2 acts on lungs. And we'll talk in detail further. Okay, now let's talk about these receptors. What's alpha and beta? So alpha 1, alpha 2, beta 1, beta 2. So alpha 1, once again, alpha 1 or alpha receptors, they found in blood vessels and they cause constriction. Remember, A, C, B, D, okay? Just put this right next to each other. A, C, B, D. So A causes C, means alpha causes constriction. B, D. B means beta, causes dilation. Okay? So alpha 1 agonist, they increase the blood pressure. An example would be phenylephrine. Okay. Alexis, question?
Can you repeat the A-B thing again?
A, C, B, D. A right next to C, B next to D. Okay. Now, your beta. Oops, Richard.
That's you.
Mute. Oh, it was you. Beta 1, beta 2. Beta 1 acts on heart. It increases the heart rate as well as force of contraction. Beta 2, they act on lungs, causes bronchodilation, such as your albuterol inhale. Okay. Excuse me. Alpha adrenergic. One more time. Alpha 1, alpha 2. Alpha 1, alpha 2. So alpha 1 adrenergic receptors, they are mostly they're present in the smooth muscles of blood vessels, the bladder, and the eye. Um, so they activate alpha 1 receptors. Then causing what? AC causes vasoconstriction by narrowing the blood vessels. What is the result? Increase in blood pressure. So whenever you're using a vasoconstrictor, the blood pressure is going to go high. When you use a vasodilator, that will increase the blood supply, but blood pressure will drop. Okay? When clinical use, where do we use it? The alpha 1 agonist. So, such as phenylephrine. So, it's used to in conditions when somebody's blood pressure is extremely low. And it also used as nasal decongestant because when somebody has nasal congestion, what happened is that the vessels in the nasal passage, they're dilated and makes the patient's nose feel like stuffy. And then these drugs, they causes vasoconstriction and opening up the nasal passages. Okay. Now, alpha 2. Alpha 2, they're primarily found in the central nervous system. So they inhibit the release of norapi, the alpha 2 receptor activation that inhibits the release of norapi, and then set up a negative feedback mechanism to reduce the sympathetic activity. So the result is a decrease in blood pressure as well as a decrease in the heart rate. Where do we use it? Pick up an example, clonidine, to reduce the high blood pressure, hypertension. Okay. Now, on the other hand, beta receptors or beta adrenergic receptors, so beta 1, beta 2, beta 1 on heart, beta 2 on lungs. Important. Somebody asks you what these adrenergic drugs cause, what they do, how do they act? So your answer should be cause a relaxation of, and I'm talking about um, your respiratory drug here, okay? Respiratory drug, such as your beta 2 adrenergic. So they cause relaxation of bronchi and causes bronchodilation. Your patient with respiratory condition, they're experiencing bronchoconstriction, so there's not enough or adequate air exchange. So they cause bronchodilation by stimulating which receptor? Beta 1 or beta 2?
Beta 2.
2. Lungs, remember, we have 2 lungs. If it's beta 1, we have 1 heart, so on, heart. Just remember that. Okay. So know that how they work. That is important. Okay. Do we just okay, now there are another receptor called dopaminergic, and they only respond to the dopamine, and they play some roles in like central and peripheral nervous system functions. There are mainly like 5 different types of dopaminergic receptor: D1, D2, D3, D4, D5, and they're involved in regulating movement, mood, reward, and some of the physiological functions. You don't have to go much deeper here. This is another way in the table. They put it like, A, C, B, D. Alpha causes constriction, beta causes dilation. Just remember that part. You don't have to go much detail. Okay, now mechanism of action. Once again, you need to know the problem and how these drugs work. So they work by, as I said, either stimulating or inhibiting your adrenergic receptors based on if they're agonist or antagonist. Activated by the neurotransmitters or the chemicals such as your API, norapi. In which system they belong to? The sympathetic nervous system, which controls your fight or flight response. So agonist will stimulate the receptors, antagonist will block the receptors. Okay. So if they're agonist, they will produce same type of action or response what API and norapi does. And if they're antagonist, completely opposite to that. And as I said, mixed ones, these drugs stimulate adrenergic receptor directly and then promote norapi release, such as your ephedrine. So, and they can also indirectly stimulate release of a neurotransmitter, which can then poke to produce causal response. Now, once again, the drug effects, what response do we see in the body? Now, once again, alpha 1, alpha 2, beta 1, beta 2, A, C, B, D. Alpha causes constriction. So if they're agonist, they will cause vasoconstriction. And whenever there is a vasoconstriction, blood pressure is going to go high. Example, phenylephrine. As far as alpha 2 agonist, they inhibit the release of norepinephrine, and they will lower the blood pressure, such as your clonidine. Then beta 1 and beta 2. Beta 1 acts on heart. So they will increase the heart rate as well as force of contraction, increasing the cardiac output. Example, dobutamine. On the other hand, beta 2 agonists, they act on lungs, causing what? Bronchodilation. Example, albuterol inhaler. Everybody clear about alpha 1, alpha 2, beta 1, beta 2? Grace, you have a question?
Yeah. So the ACBD wouldn't apply to alpha 2. Is that correct? Because it's stopping the release of norepinephrine? Okay, good. Thank you.
Okay, next slide is very important, guys. Okay, very important. Know this, these three terms: ionotrope, chronotrope, and dromotrope. So the drugs might be producing a positive or negative effect. Okay, So what do we need to know here? If a drug is a positive inotrope, what type of response in the body are we looking at? Positive inotropes increase the force of contraction. Suppose patients with a cardiac condition, okay? Cardiac condition. What happens in like when the heart is not pumping well? Heart is a pump, right? It's a pump, which pumps the volume, right? And if it's not pumping well, the volume is kind of backing up, the cardiac output is reduced. So in order to increase the cardiac output, what we can do is increase the force of contraction. Once you increase the force of contraction, strongly contract, and it is able to empty the ventricles and push the blood out, which increases the cardiac output. Make sense? So remember this, positive inotropes increase the force of contraction. Just keep in mind the heart, okay? Number two, chronotrope. Now, chrono is also, in other words, simple words, you can say chrono, a dial. What goes on the dial? Time, correct? And what goes along with time in our body? The heart rate. So positive chronotropes will increase the heart rate. Now, what is the outcome when we increase the heart rate? Means the pump is now acting quick, correct? So when it acts quick, what is it doing? It's trying to pump more, right? We are increasing the cardiac output. Once again, we are trying to solve the issue when heart is not pumping well. Correct? Third one, positive dromotrope. Now, dromotrope increase the conduction. Now, once again, think about heart. Here, all these things we're talking about heart. What are the problems with the patients when they're not pumping well? Well, either they're not contracting strong enough, they empty out the ventricles, right? Now or it's not beating at a pace it should be. Third is, I want you to think that how does the heart contract? It receives a signal from where? Your SANAV node, correct?
SANAV nodes.
Yeah. So those are the signals, the conduction. And these positive dromotrope increase the conduction. So that also, once again, heart is beating better and is increasing the cardiac output. So we are just trying to resolve the problem related to lower cardiac output. Are you able to visualize that, what we're trying to do here?
Are you talking about like increasing like ejection fraction? Like the force of the heartbeat?
Just keep it in simple way that you are trying to maintain the normal flow. Okay, heart is a pump. What does it maintain? The blood flow, right, to the body. So when heart is failing or not strong enough, what is happening? The blood supply is going down, right? The output from the heart going to the body, that's reduced. So these drugs, by using different methods, by increasing the force of contraction, making the heart to beat faster, increasing the conduction, which is once again telling the heart to beat, right? We are trying to increase the output of the heart, which is the blood supply to the body. Make sense? Okay, Alexis?
So each thing is stimulating something different when with the heart to make it work.
Yeah, we have one goal to increase the cardiac output, which is more blood, right? And we just these drugs work different ways.
Okay.
Different drugs has a different way to stimulate the heart to pump better.
So one drug might be given to stimulate the AV node. So we're stimulating that, and then the second one you said the chronotropic effect that would make the heart pump faster.
Correct. And it's not that you give all together. It's I'm just, different because everybody may have a different problem with the heart, right? So based on whatever they're experiencing, so we target that part. Yeah. Daniel, you have a question as well?
Yeah, I think you answered it. It was more so if you take one drug, one beta, one drug, it's not doing all of these. It would be specific to each condition. So I think you kind of
Yes,
answered
ma'am.
that.
All right, perfect. All right. So, but this slide is very important, okay? That's to know that. And another thing I want you to do is, and you will see it further. I believe it's next week. You will see in the heart drugs. Add some examples as well, a couple like, okay, along with that, so you kind of have a better idea. Okay. Now, with your beta receptor, right? Beta 2, if we talk about beta 2 are related to what? Lungs, correct? Two lungs. Beta 2 to two lungs. They causes bronchodilation. Remember somebody with asthma, COPD, right? Not able to breathe. And when you stimulate the beta 2, it causes open up the airways. Now they can breathe better, better air exchange. Okay. Now, when you're doing it, few things to remember, and those are important to know. And I'll give you an example of albuterol. Albuterol inhaler. What does it do? Causes bronchodilation, right? That's what it is. So the patient can breathe better. But you have to look into certain things which can happen along with that when you're trying to help them breathe better. Patients' heart rate might go up. So know that part. When you're doing it, it can stimulate the heart to beat faster as well. It could be a little irregular. Some patients, I would say majority of the patient don't see or experience that level of severity. But some patient, it may be a little bit more worse that it's irregular heart rate, fluctuating a bit, or some may feel like little hands like in the beginning. I'm talking about first couple of uses, they may say have little tremors in the hand. Um, if they're mild, they're okay. Educate the patient that it will go away shortly. It just temporarily, it may happen in certain patients. You may have to adjust the dosage as well. It might be a little too much for them, but that's usual, normal. But if it's they're doing like that, well, that could be a problem. So we got to stop in that case. But mild, that is expected. Okay, right? Now, other effects of beta 2, like on the urinary, if that part we talk about, it causes relaxation in the uterine muscles. Glycogenolysis, which is the pathway in which glycogen breaks down to glucose. Okay, and then I'll actually explain this when we talk about the drugs. May not be clear here. Now, what do we use it for? Now, bronchodilators to dilate the bronchioles. Okay, so somebody with like asthma, those conditions, that's where we use these beta 2, such as, once again, pick up some examples, attach it with each class so that you can see things clearly. So for these, pick up albuterol. What does it do? Now, some drugs, such as your norepinephrine, they are very common in your nasal congestion, those sprays. Once again, what they do here, they causes vasoconstriction. Here, what is the problem? Dilation of vessels. That's why the patient feels stuffy nose, clogged. And when you cause vasoconstriction, now the inflammation, that swelling in the passage is gone, and their airway is more open now. Okay? Pick up example of this phenylephrine. In the same drug, you might see in a different formulation, such as ophthalmic eye drops. Same drug like epinephrine. What does it do here? It reduces the intraocular pressure, too much pressure in the eye. So it can be used in glaucoma patients, open angle glaucoma. Closed angle is always a big red flag. Patient should be in the hospital. Closed angle. Open angle is something which you can manage. Okay, now for another condition, bladder issues, it relaxes the detrusor muscle, the muscle which is involved in filling and emptying the bladder. Okay, it allows the bladder to relax so they can fill completely, because some patients, they may have bladder issues that even though it's not full, they feel like it's full. We're gonna go to the bathroom. So this allows longer period for them to let the bladder fill. Okay, an example here is mirabegron, the mirabetrol, very commonly used in female patients. Now the drugs, as far as the cardiovascular indications, they also called as like pressors or vasopressors. And these drugs, most commonly, they're used in when patient is in shock. Right? What is a shock? Like, when you get a shock, what happens? Everything kind of frozen, right? So here we're talking about cardiac output. So when you're in shock, what happens to the cardiac output? Up or down?
Increases.
Increase.
In shock? Down. Okay. Suppose you're doing something, okay? You're doing something. And you say, oh my goodness, like all of a sudden you're in a shock, something. What you do? You stop doing whatever you're doing, right? So similarly, heart is supposed to beat and pump. So if it's in shock, what's going to happen to it? Is it going to beat or is it going to stop beating? It's going to stop beating, right? And that's where we use these drugs to increase the cardiac output. Once again, problem with our pump when it's not pumping. So in shock, if it's not pumping, well, we need to make it pump, correct? In order to increase the cardiac output. Agree? Make sense? That's where we use these drugs to pace up the heart. That's why they call pressors, vasopressors, pressing it to increase the cardiac output. Examples here. Your dobutamine is very common here. Then your dopamine, epi, norepi, phenylephrine, these drugs used in different formulations, but that's what exactly they do. They press, increase the output. Or you shouldn't give, and now, okay, whenever you press, okay, whenever you press, what's happening to the pressure? Means here blood pressure. Is it going to go up or down? Up, right? So which patient we shouldn't be giving it to? Whose pressure is already up, right? What they call hypertension, correct? So somebody already has high blood pressure, we should not be giving it to them. because we know it is going to raise the blood pressure, right? Ela, you have a question?
Sorry, when you say go into shock, do you mean like neurogenic shock? Because that's why we thought when you said with the heart rate, usually increase when you go
So
into
suppose
shock.
somebody is going through a cardiac shock, okay? So cardiac muscles are not contracting. There's the cardiac output is not there or low. So now you are pressing the cardiac muscles and contraction and increasing the cardiac output.
Got it. Okay. Thank you.
Um, then adverse effect, okay? Once again, it's pacing up, pressure going up. So that high blood pressure, that could be something, an adverse effect. Because of that, the patient might be restless, headache, and all that can happen. Now, this is about the alpha. Beta, remember I told you, pick up an example of albuterol, that your patient may experience mild tremors in the beginning, some nervousness, okay? Heart rate increase. So make sure patient aware about that, that it is going to alter heart rate and going up. But if it's too much, too fast, well, that is something we need to look into, that either decreasing the dose or is it something not maybe appropriate for them. But mild is okay. All right. Okay, now what if somebody is experiencing toxicity from these drugs? Well, we need to manage. Primarily, what you're doing here is it's just managing the symptoms. It's a symptomatic treatment, symptom management only. It's not that there's any reversal agent, antidote. You're just managing the symptoms here. Okay. Now here's the drug, dobutamine, your vasopressor. Once again, what it's used for? Increase the cardiac output. Increase the cardiac output. What type of patients? What is the problem in the patient? No problem.
Circulatory problems,
I'm
circulation,
sorry. Say that again.
circulation,
So technically here, the patient who has low
Heart failure.
cardiac output, your heart failure patients, right? Heart is failing. So you increase the myocardial contractility and stroke volume. You need to increase the cardiac output. That's what you're doing here. Okay? Remember, pressors, vasopressors. Same with your like your dopamine and all that. Um, there's nothing different. Similar here with epi, norepi, no difference at all. And epinephrine, have you guys heard about EpiPen? That's what the drug is. So this is the drug of choice for treatment of anaphylaxis, anaphylactic reactions, EpiPen. Okay. Same here, your norepi. You don't have to remember anything different. And phenylephrine, same thing. Some drugs you may see in certain formulations, some and others, like your phenylephrine, you will see more commonly in nasal congestion products or eye products, ophthalmic ones. Nursing implications. Well, important once again, assess your patient thoroughly so that you can prevent any complication, anybody allergic, any other drug they are taking, any underlying condition which can put them at high risk, you should not be giving it to them. And have a set of baseline your vital signs so that you can compare it. Okay. Now, monitoring vital signs as well as these basic things like the pulses, skin color, temperature, capillary refill. Why they are important and relevant? We're talking about circulation here, right? The volume is it flowing in there. So if the circulation is normal, the skin color should be normal, the temperature should be normal. But if it's not, well, the skin might be cold and the color might be cyanotic, correct? So we need to assess these symptoms. Any question?
I have a question. How do you assess capillary refill?
Okay, so for example, you know, you have a patient with this issue and you need to assess the capillary refill. Um, for example, on the toe, right? So you press it, okay? You press it hard and let it go. So it should fill up like in less than 3 seconds or so. Okay, the color back to that pinkish. Um, but if it's not, well, then it's delayed um, capillary reflux.
Okay, so like when you press on the nail or the toe and it turns white, and then how to turn back to pink.
Now,
Okay.
remember that you're pressing something to go out. That's a blood, right? You're pressing it. And now when you open it up, now there's less pressure there now. So it should come back from high pressure to low pressure and fill it up back.
Got it. Thank you.
Mhm. Anyone else? Any other question, guys? Okay, let's move on. Nothing to worry about. No. Okay. Now another thing here is, in case of nasal products, if it's a nasal decongestant such as phenylephrine, make sure these drugs, the nasal ones, they're not used for long term. Okay? Not more than 3 to 5 days, because it can cause rebound nasal congestion. These products are not meant to use for long period. We're talking about nasal decongestant, phenylephrine. And now, how do you assess, like, capillary refill is one of them, as, we talked about, and then um, temperature, the color of the skin. So similarly, now when heart is failing, it's not pumping well, right? So it's not pumping the volume. What's happening with the volume? It's backing up. When the volume backs up, the fluid backs up. What do you see in the patient? Edema, right? So if the edema is reduced now, that means it's working, right? Now, when your heart pumps well, the fluid passes through the kidney, filters through the kidneys and go out as urine, right? So if the urine output is increased, means your pump is working well now. Okay? Vital signs are normal. Because when it's not moving, circulating, while your temperature goes down, and as a color and all that, things changes. So you need to see, and also level of consciousness is also an important factor. So monitor two things, good and bad, the therapeutic effect and adverse effect. With your heart failure patient, it's important you take their daily intake and output, as well as daily weight, intake and output, so that you're making sure that whatever you're putting in is the heart pushing it out or not. If their weight is increasing, why means that pump is not fully functional. So anybody gaining weight 2 pounds or more in a day, and 5 pounds or more in a week, that is a potential problem. heart failure. Okay. All right. So I'm gonna skip the question, guys. Okay, because we gotta move on. All right. You guys ready for a break? Yeah. It's 10:07. Let's be back at 10:17. Okay. Thank you.
Professor,
Yes.
I came late, and I was just wondering if you could check me in.
Okay. What time did you come in?
I think I came in at 9:20.
9:20. What happened? Where you got stuck?
My Wi-Fi shut down, like it reset, and it took a while to start back.
Okay. Mm. All right. I checked you in. Okay.
All right, thank you.
You're welcome. Okay, welcome back, everyone. Let's turn the cameras on and start the next chapter. Excuse me. As I mentioned earlier, that some chapters are completely opposite to the other ones. So this chapter is opposite to what we discussed in the previous chapter. Here we'll talk about the drugs, which are adrenergic blockers. Okay. So all the facts completely opposite to the previous chapter. So they are also called adrenergic antagonist or sympatholytics. Means breaking down, something to break down lysis. So they inhibit the action of sympathetic nervous system by blocking adrenergic receptors. Which ones? Alpha and beta. Correct? Same receptors we're talking about, but just an opposite response. So it's the same drugs, just different names. Adrenergic antagonists, sympatholytics, or they're also called, if you specify based on the receptors they work at, like alpha blockers if they're blocking the alpha receptors, beta blockers if they're blocking the beta receptors. Okay. So based on the receptor, that's how they're named. So if they are alpha blockers, their mechanism of action would be what? That they inhibit alpha adrenergic receptors by preventing the norepi from binding, which leads to vasodilation. So the previous one were causing what? Vasoconstriction, correct? Increasing the pressure, correct? Blood pressure increasing. Here, they're going to cause vasodilation. And what happens to the blood pressure here? Goes the other way, right? Down. Correct. So what do you think would be a risk in these patients if they're taking these drugs?
Hypotension.
Hypotension, especially your older patients can fall, right? Okay, perfect. Now, alpha blockers, alpha 1 blockers. Example, your Zosins, like your terazosin, prazosin, doxazosin. They're used for hypertension as well as for BPH. Older men with benign prostatic hypoplasia, BPH. Alpha 2 are not much used, very, very rare, because they can increase the norepi and also can increase the blood pressure. So we are focusing on alpha 1 blockers here. As I said, for hypertension, for BPH, very common. And also there's another condition called Raynaud's syndrome or disease when in exposure to extreme temperatures, especially the cold weather. So they see like a cyanosis, like the skin, the tips seems kind of bluish because reduced supply of oxygenated blood. And by giving these medication, you can cause what? Vasodilation. And when the vessels are dilated, more blood reaches there and should return to the normal color. Now, as far as beta blockers, they block the beta receptors. Beta 1, beta 2, beta 1 on your heart, beta 2 on your lungs, correct? So beta blockers on your heart, they're usually for what? Hypertension, correct? The drugs ending with LOL, those are your beta blockers like propranolol, metoprolol, nadolol, all these are your beta blockers. Okay? Yes, Alexis.
So you're saying for these drugs, are when you take them, you're at risk for hypertension, or they treat hypertension?
Okay. The problem we are giving these for hypertension. Okay. But when you are giving something to bring their blood pressure down, that's what we are trying, right? If somebody has high blood pressure, what's our goal? To bring it down. And when you're trying to bring it down, now every individual is different, right? It's a different human being. Response might be different. They may have different underlying condition. They might be taking different medications a lot. So the highest risk is completely opposite to whatever the problem is. Problem is high blood pressure. When you're trying to bring it down, there is always risk that it goes a little too down than what you are trying to achieve. And that's why we say there's a risk of hypertension. Yeah. All right, let's talk about these things a little more detail. Um, Now, as we just talked, it causes dilation. Causes dilation. So one more time, alpha blockers block the alpha receptors, preventing norepi from binding. And if norepi binds, what would have happened? Vasoconstriction. And vasoconstriction increase the pressure. So once you block norepi, it allows vasodilation and reduce the blood pressure. So alpha 1, they block alpha 1 receptors, alpha 1 blockers. Causes dilation of the vessels. An example, they end in zosin, prazosin, doxazosin, terazosin. What conditions? For hypertension and BPH. And the biggest risk is hypotension. Then there are few drug classes that you have to be very careful. They should not be given together because patient will be at even more high risk of hypotension. And I'm going to mention those. Now,
Professor,
these
I'm
alpha
sorry,
blockers,
what is BPH?
benign prostatic hyperplasia. And I will explain in a little bit more details when it comes, okay? It's common in older men after 60, 65. Now, alpha blockers, it could be selective or non-selective. Selective means that they target a specific single receptor. Non-specifics are that they are not selective, and along with whatever the target is, it may produce action on some other receptor as well. Okay. Okay. Let's now start. Alpha blockers. Alpha blockers, as just discussed a couple of times earlier as well, they cause vasodilation. So somebody asks you how do they work? Well, they cause vasodilation, vasodilation. And if they ask you what condition, well, there's example here, renal disease, right there. And it increase the blood supply in those areas. Okay. So the other use, as I said, the BPH. Now, here this table shows you on what system, what type of effect it produces, like on cardiac system, right? On heart. What does it do? Reduce the tension, right? Hypertension, blood pressure goes down, and that can put your patient at risk of orthostatic hypotension. So this is the biggest concern here. Always remember, anytime you see as a class alpha blockers, or you see a drug which falls under alpha blockers, the biggest concern is hypotension. Is that clear? That's very important. Orthostatic hypotension, a sudden drop in blood pressure when standing, or it can cause like fainting, dizziness, and when the blood pressure drops, your patient may have kind of headaches and all that, but falls due to orthostatic hypotension is a very high risk. I'm not worried about any other part, but let's now talk about the drugs, alpha blockers, and let me explain you about the BPH as well now. Okay, so that you can understand what the problem, how we're trying to fix. Alpha blockers, okay, tamsulosin is one of the most common one used in BPH. The full form of the condition is benign prostatic hyperplasia. Okay, that's the most commonly used. Now, what the problem is, I want you to think something. This is a condition associated with older men when their prostate gland, okay, prostate gland. Now, try to visualize. In your backyard, you have a water tap to water your garden, your plants in the backyard. You have a hose connected. Okay. Now, when you open the tap, what happens? The water flows to the other end, right? And you can water your plants. That's the normal process. Similarly, bladder is full and somebody goes to the bathroom and it should flow freely. Correct. But when somebody has BPH, benign prostatic hyperplasia, now I want you to go back in the backyard and put a clamp on your garden hose. What's going to happen?
Urinary retention and decreased flow.
There you go. So now if you put a clamp on your garden hose, the flow is obstructed now, right? Less going out, it's like dripping now, and more backing up. Retention. Same happens with these patients. The prostate gland, it's inflamed, and because it is around the urinary passage, so it is now pressing it. That passage is tight, and when they go to the bathroom, they have difficulty passing the urine. It's dripping, more retention. Now that is discomfort, painful, and urinary retention puts your patient at increased risk of UTIs. And then frequent UTIs, more severe, it can go up, infect the kidneys and pyelonephritis. Okay, so that's what BPH. Is it clear, Carly? You understand it? So that's exactly the problem is now what we are trying to do here. We're trying to relax it. We're trying to relax it so that the passage opens up and they can go urinate. Okay. But the biggest risk, once again, biggest risk. And why? Remember who we are giving it to. Older patient, right? Older patient might be already, they're weak, they're slow, drowsy, weaker. So they're at increased risk. Kimberly, question?
So for this, would we see on a test like alpha blocker, or would you use tamsulosin on a question?
It depends. Depends. It could be any.
So we need to know both. Okay.
Absolutely. Know the class, know the drugs under it.
Okay.
Okay. And you don't have to memorize every single drug, but if always pick up the important ones, and like this tamsulosin is one of the most common ones used.
Yeah, it's just I'm familiar with the drugs and their action, just not the class. So,
Okay.
okay.
So yeah, so always whenever in each chapter, you should write down the class and then the common example under them so that you know which one. Like leaving the hints, right? You know, TEMS, LOSIN. So write down there, alpha blockers, they end with this so that you can identify.
Okay.
Yeah, always leave those hints. That'll make your life easier.
Okay.
Okay. Now we know the problem, we know the solution, and while we are trying to fix the problem, we know the another problem, hypotension, right? That can happen. Well, there's another angle. Yes, we know it puts your patient at risk of hypotension, but we also need to make sure we do not give it anything else which can increase the risk of more severe hypotension, correct? Like alcohol. No. And very important, guys, very important. ED drugs, erectile dysfunction drugs, like your sildenafil, vardenafil, tadalafil, like Viagra and all that. Now, why? Because they also cause vasodilation. They cause vasodilation, increase the blood supply, correct? Now, two drugs with additive effect, patient is definitely gonna end up in emergency department if these given together. They should never be given together. Similarly with the nitroglycerin, because that also causes what? Dilation, correct? Vasodilation, drops blood pressure. So this is a big thing. Make sure you have complete clarity about it. They should never be missed. Okay? Let me add another thing. You may see this drug in female patient in for one condition. That is if they ever develop kidney stones. Kidney stones, because they do what? Causes dilation, open up the passage, and you tell them to drink more fluids, it can help flush the kidney stones quick. Make sense? That is the only time you will see this drug. Otherwise, shouldn't be given in to female. Okay. Now, because you know it can cause hypertension, educate your patient, all safety things. Okay. Sit before you stand, change position slowly. All those things are real important because we need to cover that safety part. Hypertension. If you try to visualize everything we're talking about, it's focused on that one angle of hypertension, right? Either we're saying don't take it with this because, once again, increased hypertension risk. If you're telling them change position slowly, again, hypertension, everything is associated with that hypertension part. Okay. Any questions so far, guys? Okay. Now let's talk about beta. Beta 1, beta 2. Beta 1, we know associated with heart, beta 2 with lungs, correct? So beta 1, heart, 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 heart. Beta 2, lungs, 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 lungs. So beta blockers, beta 1, what they do? If they're agonist, they increase the heart rate, right? If they're blocker, they will decrease the blood pressure, correct? So which patients or disease condition we can use it for? Hypertension, correct? So now remember how to identify beta blockers. Kimberly, see another example, how to remember them. Write down beta blockers and just a little tip right next to it, LOL. Write down LOL. Any drug you see ending with LOL, that is a beta blocker. Okay? And I will give you a few more tips that what is important about beta blockers. For example, beta blockers, especially non-selective. Non-selective. Now, selective one, where they will be acting. What is the site of action for these? Heart. Yes, heart, right? But if they're non-selective, they will work on heart. But even though we don't want it to go on a walk towards the lungs, but it may have an opposite effect on the lungs, causing constriction rather than dilation. So the patient who has asthma COPD, while they're already struggling to breathe, and if these drugs reaches there and cause constriction, what's going to happen? Make their condition more worse. So we don't use non-selective beta blockers in patients with asthma COPD. Make sense? All right. Another point. If your patient is diabetic, diabetic means the blood sugar is high, correct? Now, what are you trying to do with the drugs? You're trying to bring the blood sugar low, correct? So when you're trying to bring it down, there is a risk that it may come down than wherever you want it to bring, right? There's always risk. Something overdoing, correct? Now, these beta blockers can mask the symptoms of hypoglycemia, low blood sugar, right? How do they feel? Like chills, a little shaky, correct? And these beta blockers can mask those symptoms. The patient may not experience those symptoms, and a healthcare provider may not notice those symptoms, and the blood glucose can drop without any signs and symptoms. So you should be careful. Daniel, you have a question?
Yeah, I was just curious why it does that.
Because
why do they
remember,
mask?
because when you have high blood pressure, how do you feel? Anxious, sweaty, shaky. So that's how it works. It relaxes everything, causing dilation, slowing down things. And even though it's not directly related to that problem, the asthma COPD, but because the action is that and the response is in that manner, so it can mask the symptoms, even though it's coming from somewhere else, but because they are similar, so it may mask the symptoms. Okay.
Copy. Thanks.
All right. You're very welcome. All righty, guys. Now, if somebody asks you how do they work, mechanism of action, beta blockers. Well, we all know the name tells us they block the beta receptors, correct? Beta blockers, blocking beta. And technically, you blocking what? Your epi-norepi, because epi-norepi are the ones responsible to increase the blood pressure by causing constriction. And these drugs causes dilation. Agreed? Okay. Now, the selective one, once again, on the heart only, non-selective, will go on a walk and may cause unwanted, undesired adverse effect on lungs as well. And those are undesired, unwanted, because they cause opposite effect, causing constriction. Now, what can they be used for? Well, the most common, hypertension, right? Somebody's blood pressure is high, we need to bring it down, can be used. Angina. What is the problem with angina? It's an imbalance between oxygen demand and supply. Heart is aching. It's crying, saying, I'm not getting enough, right? And what does the beta blockers do? It cause vasodilation, increase the supply, correct? So they were deficient, and these drugs increase the supply, so well, we can use it, right? They also have cardioprotective properties, especially patients with myocardial infarction who had a heart attack. Keep it safe. It can be used for arrhythmia. And this also helps in anxiety, slowing down. Also, ophthalmic drug, beta blocker, most commonly timolol. It's used to decrease the intraocular pressure. What is glaucoma? Increased intraocular pressure. What does that mean? Well, hypertension in the eye. Simple word. And it can help there as well. Another, I would say, uncommon practice. It's called stage fright. Anybody heard about it? Stage fright, right? So maybe a single dose you might see given to somebody who's not comfortable speaking in front of like the full hall, like full 200, 300 people. They have to present something and they're all shaky. Well, you may see this drug. Okay. So adverse effect. Well, think about completely opposite what we are trying to fix. We're trying to fix something fast, right? Blood pressure is high, more tension, heart rate beating faster. And if you fix it too much, going completely opposite direction means going slower. That's the most common thing can happen. Correct? Important. We use this drug to decrease the blood pressure, right? And if heart is beating fast, tachycardia, well, we see that this drug will reduce that as well. And it's important to assess your patient before you give this medication. Why do you think it's important to assess your patient before you give this medication? Any idea? Now, what is the criteria? Why are you going to give this beta blockers to somebody? Because they have high blood pressure, correct? Right? Is it possible somebody usually have high blood pressure may have a low blood pressure someday?
Yes. So you want to
Absolutely,
make
yes.
sure that to test them
So
because
you
if they
gotta
have
make
too
sure,
low blood
yeah,
pressure, then the blood pressure can
correct.
go
So
lower.
somebody's blood pressure, heart rate is already low. Why would we give it? We're gonna put them at risk, right? So these drugs comes with a requirement. Usually all hospital clinic you go, they have those parameters and you have to punch in the numbers, blood pressure, heart rate, right? And usually doctors, they have directions like hold the dose if this is below this, right? So you have to enter, you have to initial approve it before you give it. Okay. Now let me tell you one important thing and know this number. Anytime you're taking the pulse, okay, if it's below 60 minutes, 60 beats a minute, okay? If it's below 60, what a super nurse is gonna do?
Hold the medication and notify the provider.
There you go. Hold the dose, call the doctor. So remember this magic number. Below 60, hold the dose, call the DOCTOR. They like it, they don't like it. Okay.
Just on the beta blockers or all blood pressure
All blood
medication?
pressure medication. All blood
Because
pressure
it's
medication.
common that people have pulse below 60, especially like the older over 65, they have pulses like in the 40s and 50s.
Exactly. So that's why I said that usually the doctors, they have those parameters set. They will provide you, okay, below this for it's not Okay, when we talk about something, we talk about what is common in majority of the people, not in everybody. Everybody is different. Somebody's with blood pressure, which is high or low, or as you said, the pulse rate high or low, that could be their normal. So that is based on the particular patient, and the doctor gives you that number. Okay, but we're talking about commonly used majority of healthy adults. Like, blood pressure, we say 120/80, but everybody doesn't have that, right? It could be different, but we talk about what are the common parameters used, standards used.
So if it's normal for that patient, because patients usually know when their pulse is low and that's their normal, then that would be okay to go ahead and give the dose.
So it's not about just the patient is telling you. You got to contact the provider.
Okay.
Because you don't know, and the patient, you can't just act based on what the patient is telling you. Yeah, you can get that information, pass it on to the doctor. Hey, this is what my assessment is. This is what the patient told. I mean, what should I do? But they may say, oh yeah, we have a documentation here. This patient usually stays low than this, so that should be fine. Document it. Perfect.
Okay, thank you.
Yeah. Remember this thing. Remember this thing. Doesn't matter how big or small thing is, always document. Do not decide on your own. Keep yourself safe. Keep your license safe. Ask. All right. Moving on. Long-term use in males can cause impotence, but it's not that high of a risk. But I am worried about this bronchospasm, beta blockers, and who? Not everybody, not normal healthy adults. I'm talking about patient who has respiratory conditions, COPD, asthma. That is a problem. So when there's a new prescription, assess the patient if they have any underlying condition. If they have this, well, that is a big no-no, right? And as I mentioned earlier, non-selective beta blocker, they can mask the symptoms of hypoglycemia. Ask the patient, are you diabetic? Do you take any medication? To prevent that risk. Well, would you see these still given? Yeah, all the time. But what can you do? Well, you monitor their blood glucose more often, correct? More frequently. That's all you're gonna do. Usually they're like, when the blood glucose going down, they feel like hungry, tremors, they're irritable, they're confused, and these can be masked. But mostly, again, there might be exceptions, mostly sweating still present. Okay, so the patient, everything else is same, they're diabetic, but they're sweaty, check their blood glucose. Okay. Management of toxicity, technically, it's once again, it's more symptomatic. This not reversal agent. Now, another important thing I want to add here, based on what the risk we were talking about. Beta blockers, when given with certain other drugs, can put your patient at a high risk, such as I just mentioned about diabetic patients, right? They can mask the symptoms of hypoglycemia. So somebody is taking diabetes medication, that could be a risk. So that is important. Alcohol. Alcohol. Alcohol in the beginning, initially, increase the blood glucose, but it can drop it suddenly after that. High risk. Okay. Somebody's taking diuretics. Diuretics, what they're used for? To decrease the blood pressure. When they're taken together, increased effect. Okay, and they don't go well with the penicillin as well. And anticholinergic. So diuretics, anticholinergic, your diabetes medications, penicillin, and alcohol that is associated with increased risk. Now, once again, how do you identify? They end with LOL. LOL. Okay, now this drug is used to bring the blood pressure down, correct? Bring the blood pressure down. With organ, one of the important one, heart, correct? A vital organ. So we do not want to do anything to upset the heart. What that means by that these drugs should be taken consistently. Okay. Do not skip a dose. Do not double up a dose without asking the doctor first. And most importantly, never, ever, ever or never abruptly stop them. Heart is not going to like that. Never abruptly stop. Very important. So there's some drug classes which has much more higher risk consequences associated if they're abruptly stopped. And these are one of them. And once again, if somebody's heart rate is low, are you gonna give it?
No.
You're gonna do this? No, no, and no, right? All right. There's some other, I just put in here, you don't have to memorize anything differently. I'll tell you for any drug if you have to, but I just wanted to put some more names here, okay? For this drug, Asmolol, what I want you to know here is this drug, primarily you will see in hospital emergency departments, like somebody is experiencing a heart attack, right? So in acute situations, you will see this drug used given as an IV. They try to bring the blood pressure in a step down approach like 20s slowly. You don't drop the blood pressure suddenly, always a stepwise ladder approach, little by little, little by little. Like they say in 1 hour, just a 20 points. Next hour, maybe another 20 points, not more than that. Put a patient at high risk. Okay, very commonly used for supraventricular tachydysrhythmia or tachycardia. Now, what happens when somebody is having a heart attack? The heart is failing. Now, to compensate, to increase the supply, heart is beating faster. When heart beats faster, what does it call? Tachy, right? Tachycardia. When it's slow, it's bradycardia. So tachydysrhythmia means the rhythm is abnormal, and which side? Tachy, faster. Or it could be tachycardia. And supraventricular, what does it point towards? It's telling you where it's originating from. Okay, supra, above the ventricles. That's where it's originating. Everybody clear? So that's the important part about that drug. Nursing implication in general, look for any underlying cause as a couple of example. I just share like anybody diabetic, and also very important about somebody with COPD, asthma. Look for those things. Any interactions which can put your patient at high risk, right? Once again, educate, educate, educate. Proper use. Do not abruptly stop. Do not miss. Do not double dose. And hold the dose. Call the doctor if below 60. Right? Okay. I'm not worried about that. Okay. Nothing different, nothing different, nothing different. Okay. Now monitor therapeutic as well as adverse effect and see what you're giving for. If it's for hypertension, well, look at the baseline vital signs, and now after you get the medication, where are they at? If you're giving it for angina, is the patient saying that the pain is reduced or absent, right? So based on whatever the symptom you're trying to treat, manage, you should be assessing your patient. Now, because it's associated with heart is a pump used to pump the volume, the fluid, right? And if it's not pumping well, the fluid will back up. Signs and symptoms like weight gain, edema. So always 2 pounds or more in one day, 5 pounds or more in a week. And if you see edema, that is a sign of pump failure. Now, why shortness of breath? Anybody know why shortness of breath? Has nothing to do with pump.
Because the edema puts fluid on the lung, right?
Yeah. And do you know like what type of heart failure it happens in?
Congestive heart failure.
Hey, let me give you a tip. Commonly two types you see, right-sided and left-sided heart failure, correct? Right-sided and left side. Now left starts with what? L, right? Where you're going to see the symptoms when your patient has left-sided heart failure and another L, which is lungs. Anytime your patient has left-sided heart failure, listen to their lungs. The fluid will back up in their lungs. What happens if it's right-sided? Well, everywhere else in the body, edema, all that, that's what happens when it's right-sided. Make sense?
That's when you get the edema like in the feet and all of that. Like
That is
The
correct.
legs,
So
ankles,
that's
feet.
usually right-sided.
Okay.
Left-sided, listen to their lungs.
Is it only edema that they have when it's right-sided?
So edema, then, different parts of the body, jugular vein distension, all those things you will see in that, the right-sided. But mainly with the left is now the fluid backing up in the lungs. It's like they're choking, they're drowning in their own fluid. Okay. Any question, guys? Everybody okay? Any question? All good? Okay. Okay, that's human. Okay, how about that? Good job. Excellent. Proud of you guys. Very well. Yes, A is the correct answer. Remember, the problem is hypertension. Now we are giving them a medication to keep the tension low. Now, once you remove the solution, problem raises its head, which is hypertension. Rebound hypertension. That's what the risk is. Okay. Another one. All done. Good job. Okay, everybody answered correctly. B is the correct one because we know the number. Below 60, the super nurse always hold the dose, call the doctor. Okay. Perfect, perfect, perfect. All right, so we are done with this chapter as well. Guys want to take another break? Okay, it's 11:02. Let's take a 10-minute break. I'll be back at 11:12. I'll see you in a few minutes.
Excuse me, Professor, I have a quick question.
Mm-hmm.
Do you think you could provide the questions that you have on your slides to us like after, or would it just, because there's some that you don't go through?
Yeah, these questions, we just keep it for the class only. Yes.
Okay.
Yeah. All right. Okay, guys, welcome back. Let's turn the cameras on and start our next chapter. Okay, so the next two chapters are also gonna be the same way. One, we're gonna do cholinergic, and the second will be anticholinergic, completely opposite to this one. Know one well, you will know the other one. I'll give you an example. Anticholinergic, pick up an example of Benadryl, diphenhydramine, what it's used for, and what are the adverse effects. It's always helpful to pick up a couple of most common drugs from the class, just stick right next to it. That will help you to remember what it's used for and any other drugs in the similar class, as well as what are possible adverse effects associated. Like, if it's an anticholinergic, if you're able to recall Benadryl and just think like what it's used for, like, allergies and all that. And then what are the adverse effects? Well, it makes you slow, sleepy, drowsy, dry. Pretty much all drugs in the same class, they're going to do the same thing. As long as the drugs in that class, they're targeting the same receptor, the result is going to be the same. Correct? It doesn't change. Receptors don't differentiate between different names of the drugs. If it's on the same receptor, same thing is going to happen. All right. So cholinergic. For cholinergic, remember, if the anticholinergic make your patient slow, sleepy, drowsy, dry part, here cholinergics will increase the secretion, make your patient wet, increase the secretions. Cholinergic. Okay. So these are the medication which mimic or enhance the action of acetylcholine. Cholinergic means associated with acetylcholine. In anticholinergic, they block the cholinergic receptors, blocking acetylcholine. But here, they enhance the action of acetylcholine. Okay. Now here as well, you have drugs which act directly or indirectly. When they act directly, the drugs go straight, shake their hand with the receptor. Here we're talking about the drug going and binding to the cholinergic receptors and then stimulate them, such as your pilocarpine, betanicol. Pilocarpine, glaucoma, betanicol used in urinary retention issues. Indirect acting, such as cholinesterase inhibitors, they do not go directly and shake hands. They have to find a mediator. Okay. What they do is they go to an enzyme called acetylcholine esterase. Now, that enzyme is responsible to break down acetylcholine, degrade it. When it's broken down, degraded, then less acetylcholine is available. And that's a problem in this case. So they go and block the gentleman, the enzyme, acetylcholine esterase, who breaks down acetylcholine. So once they block it, that acetylcholine esterase is not able to break down acetylcholine. So now there's more acetylcholine available. Make sense? Example. Neostigmine, it's used in myasthenia gravis to improve the muscle strength. And then donepezil, Aricept, for Alzheimer. Okay. So when we talk about these two types, either based on the location or the action, that's how they are named. You may hear calling them nicotinic receptor, muscarinic receptor, because they are also stimulated by the nicotine. That's why they call like nicotinic receptors. Muscarinic, same, they are stimulated by muscarine, which is in some mushrooms, present in mushrooms. So that's how they're named. Now, location, they are located in the ganglia of both the parasympathetic as well as the sympathetic nervous system. Okay. All these drugs used, they act and produce the action similar to what acetylcholine produce. Same effect. Okay, same effect. They're binding to cholinergic receptors. So we're gonna go over them one by one. Not here. Okay. Sorry. Now, as I said earlier, cholinergic will increase the secretion, and the next chapter, anticholinergic, will decrease the secretion. Okay, so for example, the drugs used, they may increase the gastric secretions, increase the GI motility, also increase the frequency of the urination. So somebody's, excuse me, for example, um, patients postpartum or post-surgery, they're having difficulty with the passing the urine, and these drugs can help. Okay. Also decrease the intraocular pressure, more outflow. And somebody such as their Sjogren syndrome, people have excessively dry mouth, excessively dry eyes, so these can help there as well. Excuse me. On the heart, it may decrease the heart rate, causing vasodilation. And in the respiratory tract, it may cause bronchoconstriction. It's an undesired effect. Now, in ophthalmic products, as I just mentioned, this drug or these drugs will reduce the intraocular pressure, the pressure in the eye. Which patients with what condition who has this issue? Glaucoma. Glaucoma, they have increased intraocular pressure. This drug can increase the outflow of the aqueous humor and decrease the intraocular pressure. Another example would be an eye surgery, after eye surgery, because surgery, no matter where it is, it's a trauma. So if it's an eye surgery, it's a trauma to the eye. So whenever there is a trauma, what happens? Inflammation, correct? Inflammation increases the pressure as well. That's even more stress. So this drug can help managing that condition. So usually they are used for a short period of time and then they discontinue it. Such as your pilocarpine, your carbachol, these are the most common ones used. Pilocarpine in your glaucoma. And as far as the urinary issues, botanical is used commonly. It stimulates the muscle contraction in the bladder. And myasthenia gravis, as I said, it improves the muscle strength. They can chew. And Alzheimer, such as donepezil, brand name Maricept, it increases that cholinergic acetylcholine to improve their memory and cognitive functions. Because There's less acetylcholine. And now, once again, if it is a product for bladder issues, botanical is a common one, which is a direct acting cholinergic agonist, which stimulates the muscarinic receptors. Okay, so helping patients with issues experiencing with what? Bladder, like urinary retention. They're able to pass the urine. How? It promotes the contraction of bladder muscles after surgery, as well as baby delivery. So that they do have that some period when the bladder does not have the natural tone of contracting on its own. Not in everybody, but there's a chance, and this drug can help. Um, yes, Kimberly, you have a question, ma'am?
Is it the anesthesia that is causing this in the post-op patients?
And all different factors plays a role. Anesthesia is a part of it, but that's not the only reason. And natural delivery is also one of the reasons that the body takes a little while to gain that, the natural tone as far as the bladder concerned.
Okay.
Okay. So similarly, somebody's have gastric atony, means their GI tract does not have natural tone and peristalsis. So it can increase that as well. So urinary retention, botanical is a common thing which you should know. It's an important one. Now here's another drug, cevimeline, which is used in patients called xerostomia, excessively dry mouth. Mouth is drying all the time. Okay, there's a condition, medical terminology that's it's called Sjogren syndrome. It starts with S. It's Sjogren, Sjogren syndrome. Severely dry, 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 dry. Then you have to give them artificial saliva and this and that. But here, this drug can increase that saliva, make the mouth more wet. Okay. If you're giving these drugs, you have to be careful. For example, if somebody's going for surgery, okay, and in major surgeries, they have to establish an airway, right? So they insert the tubing, and whenever there is, it's like a foreign intrusion, okay, right? Because that airway, artificial airway, it doesn't belong to your body, right? You forcibly you're pushing it in a patient. That can cause trauma. Can cause trauma because the muscles they're going to act against it, right? They're gonna oppose the entry, so it can cause trauma in order to relax those muscles. And these drugs can be given, but if they're going for surgery, the mixed effect of cevimeline, and the general anesthesia and these nerve blocking agents can cause temporarily paralysis of those muscles, especially even respiratory issues they can experience. So you have to be careful about that. Um, Now, if somebody's experiencing toxicity, okay, very important. Your physostigmine. So physostigmine inhibit the acetylcholine esterase, an enzyme, and then reverse the neuromuscular blockage produced by anticholinergic poisoning. So physostigmine is used for poisoning of or toxicity caused by anticholinergic. Anticholinergic. Okay. A good example would be um, chemical toxicity like organophosphates, your pesticides and stuff. Pesticide, insecticides, those are a good example to remember. So please know that physostigmine, that's an important antidote. Excuse me, that. Now next, another important class, anticholinesterase. So they inhibit cholinesterase, which breaks down acetylcholine. Okay? Alzheimer. In Alzheimer, the patient do not have enough or they have less acetylcholine. And you're blocking an enzyme which breaks down more acetylcholine. By blocking that breakdown, you're making more acetylcholine available. And it should result in improved symptoms. Okay? Example, your donepezil. Aricept is one of the most common ones. And then there are patches, your Exelon patches, rivastigmine, and I'll go over their use as well. Now, contraindication, basic thumb rule, anybody is allergic to that class, they should not be taking it. I'm not worried about other things here. Not much worried about adverse effect in general. I would definitely keep an eye for slow heart rate, bradycardia, low blood pressure, hypertension, and too much of salivation or sweating. That's something I would keep an eye, but nothing major to worry about. Now, here, respiratory, I'll point out one thing, especially in patients who are old with respiratory issues, because these drugs will increase the secretions, including could be in the lungs, airway, which can make it hard for those patients to breathe. Because when there's more secretion, then because it's hard to breathe. Not adequate air exchange. So just be careful. Now, anytime a patient experiencing toxicity of these drugs, well, what they're going to experience, remember this thing, sludge and anti-sludge symptoms. Sludge, anti-sludge symptoms. Now, what does sludge means? Does anybody know what that is? Sludge means you're like salivation, lacrimation, tears, right? Eyes, watery eyes, urinary incontinence, then your diarrhea, GI cramps, emesis, right? It is going to increase. Wet, those symptoms is gonna be more. That is the sign, or those are the signs and symptoms associated with toxicity from these drugs. On the other hand, if we talk about anticholinergic, the signs and symptoms will be opposite. Anti-sludge means everything is going to go down. Less saliva because they're getting dry. Less reclamation, once again, because it's getting dry, right? So all those things are going to happen. They're going to retain more urine. So in order to manage antidote, toxicity caused by cholinergic drugs can be reversed by using atropine. So know that, please. It's important. Atropine is an antidote for cholinergic drugs toxicity. Now, as you see previously, there was another one, and now you came across this antidote. And as we go over different topics, chapters, you will come across more and more antidote. So just create a list of antidote as well. I think overall in the whole course may have like 6, 7, or 8, something like that. Not more than that. Should be less than 10. Now let's go over some examples here. Botanical, important drug, botanical. Botanical is a direct-acting cholinergic agonist. Agonist. Okay, it is going to increase the secretions. Okay, for example, somebody's having urinary retention, or the natural tone of the GI tract is not there, reduced bowel motility, and these drugs can support that. So anybody post-operative, postpartum, or non-obstructive urinary retention. It's obstructive, then it's not going to help. Non-obstructive, then these drugs can, or botanicals specifically, can help them to go pee, pass the urine. So probably within, I would say, 30 to 60 minutes, they should pass the urine. Adverse effects, not much I would worry about. Once again, slow heartbeat, hypertension, those are something. And as I mentioned earlier, respiratory symptoms you should keep an eye on. Okay, important drug, donepezil, Aricept. This drug is used in patients with Alzheimer. Why? It is a choline esterase inhibitor because choline esterase is an enzyme which breaks down acetylcholine, and that is a troublemaker for these patients. They're already low in acetylcholine, and if it is choline esterase breaks down more, well, they will have even less acetylcholine. Their symptoms will be worse. So you're blocking who breaks acetylcholine so that they are not able to break more, and there's more acetylcholine available at the receptors. Okay? Everybody understand what is the problem in Alzheimer? Low acetylcholine, correct? So the solution is to increase the level, right? And how this helps? It blocks the enzyme which breaks down acetylcholine, which is acetylcholine esterase. And that's why they're called acetylcholine esterase inhibitors. Okay. Not worried much about these contraindications or adverse effect here. Not that important. This is another important drug, mementin. Okay, mementin. Now this is also used in Alzheimer. Okay, it's here because the problem is same, low acetylcholine, but it acts differently. Okay, it acts differently. This drug is called NMDA receptor agonist, and methyl D-aspartate, NMDA receptor. So these are the ones which are responsible to regulate the glutamate activity, which is a neurotransmitter associated with learning and memory. So by preventing the overstimulation of these receptor, this particular drug mementin or any other in that class help protect the brain cells from further damage. Okay, it does not do anything with the acetylcholine. It's completely different. NMDA receptor. Okay. This is used for moderate to severe Alzheimer's disease. It should help improve their memory and their focus, attention, and able to perform their daily functions more effectively. As far as adverse effect, side effect, I'm not worried much about it. Only I would say a little headache or dizziness, but nothing major to worry about. Okay, pyridostigmine. What is important here is that what it is used for. It is used for myasthenia gravis, patients with myasthenia gravis. Let's connect how it works. So pyridostigmine, it is a choline esterase inhibitor. Once again, choline esterase inhibitor. It blocks that enzyme, choline esterase, which breaks down the acetylcholine. Okay? Used for myasthenia gravis. Side effect, not that big of a deal, but common, I would say, abdominal issues. This drug should be given, I would say, 30 to 60 minutes before the meals. Okay? It helps them to strengthen and help controlling their muscles, especially that these people have difficulty even chewing. So you need to help at that point so that the drug is in the system and they can utilize these muscles to your jaw and open up the jaw and they can effectively even chew the food. Now neostigmine, pyridostigmine, and physostigmine. These drugs are used to reverse the effect of certain toxicity caused by these high-risk drugs like TCA, tricyclic antidepressant, and as an antidote for anticholinergic drugs. How does it work? For example, let's pick up neostigmine. It is a cholinesterase inhibitor. Once again, blocks cholinesterase and resulting in blocking the breakdown of acetylcholine. Which condition used in? We just previously talked like myasthenia gravis. Okay. Then pyridostigmine. This is also cholinesterase inhibitor. What it is used for? Once again, can be used for myasthenia gravis. Physostigmine, same thing, cholinesterase inhibitor. Used for, this more commonly used for antidote for anticholinergics. So know that, it's important, okay? Physostigmine, anticholinergic reversal agent, or can say to treat anticholinergic toxicity. Any questions so far, guys? No? Okay. This is the general, I'm not worried about that. Okay, this slide, once again, repetition. Remember we were talking about drug previously for myasthenia gravis? Myasthenia gravis? Remember it? This one?
Yes.
Pyridostigmine? So this drug given for myasthenia gravis, give it 30 to 60 minutes before they eat. Because these patients, their jaw is like, feel like fixed. They cannot move their jaw to chew on food. And that's why we're giving it to free up their jaw and they can chew, better muscle control, and they can swallow. Otherwise, they won't be able to chew and swallow. Okay? And another important aspect is, and that actually applies to all conditions, that be honest, truthful to your patient. But in certain conditions, there's something additional, such as those conditions which can only be managed, you cannot reverse it. Like Alzheimer, right? You can only manage, slow the progression, and just manage the symptoms. You cannot treat it. You cannot reverse whatever the loss is. Is that right? Certain condition, you cannot reverse the loss. You can only manage and kind of slow the progression the most. So be honest to the patient caretakers that these drugs are used to manage the symptoms. It is not going to cure, because patients sometimes they don't understand, and the families also, they expect some kind of dramatic changes, like that patient is now able to remember everything. They remember their family members, and then they can do things on their own. It's not going to happen. The severity might be less, but it's not going to cure it. So be honest. um, and then as we talked about atropine previously as well, this is an antidote for cholinergics, toxicity. Okay? Monitor good and bad, expected, unexpected, therapeutic as well as adverse effect. See what is expected, the goals are met or not. Okay? For example, if you're using, somebody is not able to go pee or poo, and whatever the drug you're using for what purpose, are they able to now? Well, if yes, that is a therapeutic outcome. If not, the goal is not met. So try to find out why. What is the reason? Um, but always pick up from where you started, where the problem started. Like, what are the symptoms initially, and now compare what you have current and assess positive, same, negative, symptoms are same, less, more. And that will tell you if the drug is effective or not. And the next step is to find out. If it's not, then why? For example, if the patient is having urinary retention, like after postpartum or post-surgical, we are giving them botanical so that they can pass the urine. And generally, they should be able to pass within an hour or so. If they did, well, therapeutic outcome achieved, goal met. But if not, figure out why. Do they have some sort of obstruction? Because then it's a different story. This is not going to do anything to the obstruction. If you're giving, such as your Aricept or memantine, Emenda, for Alzheimer, well, pick up the symptoms initially and assess how they are doing now, the same symptoms. Compare it. Are they improved or not? Or is it the same? Maybe it requires dose adjustment. So by using this simple technique, that pick up where initially the problem started, when they came to you for help, what the complaint was, what the assessment was, and assess the same issues now and just put them right next to each other and compare. Is it same, good or bad? Okay. Mm, okay. Let's see. Any questions? Good job. Perfect. Yes, B is the correct choice because it's saying cholinergic. Cholinergic means wet, wet, wet. More secretions. And here, increased GI motility. And like C here, don't get confused here. C says urinary retention, but we use it for helping patients to urinate more. So sometimes we kind of read half of the option and we feel, oh yeah, urinate, but it helps in passing the urine, not to increase the retention. So very good. B is the correct one. Okay. Okay, let's talk about it. Majority answered A, but there's couple, or actually 3, 4, 5 of you which picked up B, which is the correct one. Remember, post-operative teaching for patient prescribed botanical. Botanical, once again, these drugs increase, make your patient wet, wet, wet. And remember I told you, post-operative, patient having difficulty passing the urine because their bladder has not returned to the normal level or normal tone of the bladder, atoning. Okay, so you're helping at that time. It's the B. It causes bladder contraction and they're able to empty the bladder. Okay. Excellent. Very good job, guys. Very well. D is the correct choice. Remember, once again, going back to the problem, Alzheimer, the patient has less acetylcholine, correct? And donepezil does what? Block the enzyme acetylcholine esterase, which breaks down acetylcholine. By blocking it, you're increasing the level of acetylcholine. Okay, everybody agrees? Anybody different opinion in the free board? No? All right, all right, all right. Okay. All right, perfect. Okay, D is the correct choice. Remember myasthenia gravis, what I told you, 30 minutes before the meal, so that drug is in the system and they are able to use their muscles for chewing as well as swallowing. Okay, any question before we take a break? Any question, guys? Anybody? I'm just looking at everybody's face like nobody's saying anything. Are they awake? Yes,
No
looks like
questions.
yeah. No question. There you go. Now I can say yes. We're awake. All right. All right, guys. So ready for the break? Yeah. Okay.
Yes.
Now I can see
Yes,
everybody's
we
head
are.
like, yeah, 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 yes, right. Now everybody can even stand up like, yeah, right. Okay, 11:52. Let's come back at 12:02, and we'll wrap up the last chapter, guys.
Thank you.
Thank you. I'll see you shortly. All right, welcome back, everyone. Let's wrap up last chapter of the day. Excuse me. Please turn on your cameras so I can see you. I get scared, okay, when I don't see you. Like, where is everybody? Where's everybody? I'm scared of ghosts. All right, let's start our last chapter. As I mentioned previously as well, they're opposite to the previous one. So these are cholinergic blocking drugs or cholinergic blockers or anticholinergic, same thing. So they're just trying to give you a hard time, right? They could have just named one anticholinergic, right? That's what I used to say. Like, why did you like, all the drugs, when I was in the pharmacy college and those times I'm talking about 94, 95. There were two types of drugs. The names were hard. It was cancer and HIV/AIDS. And we're like, why are you naming it so hard? You gotta do it's just a name, just use something simple. And well, if you look at the drugs now, everything is getting more and more complex. I don't know why they can't just name it simple. Sometime you see like, oh my goodness, seems like something big, and you see like, oh, these are just omeprazole sprinkles or just a liquids form. The name is so hard. I think there's so many drugs came out and this brand, generic, this and that, that then they try to kind of go to the complex names which are not used by others. It gives them like a little easier way, rather than keep looking, searching for the names and then finding out, oh, it's been registered previously. Oh, this is too close. So they want to make sure that it's completely different and people can kind of distinguish easily that, oh, that's what it is. And anyways, makes it hard. So we'll talk about anticholinergic, the drugs, associated use, adverse effect, interactions, and important aspect related to your nursing care plan when your patients are on one of these medications. Cholinergic blocking drugs, anticholinergic, once again, they are going to block the cholinergic receptors. And which chemical associated? Acetylcholine. So are they going to increase or decrease the acetylcholine?
Decrease.
Decrease. So previous chapter, we're talking about cholinergic, where your patient becomes wet, wet, wet. Now they're opposite. How are you gonna pay your patient gonna feel here?
Dry.
Dry.
Yeah, and remember, anticholinergic, pick up one example, like your diphenhydramine, Benadryl, slow, sleepy, drowsy, dry. That's what's going to happen to your patient. So if they are slow, they're sleepy, they're drowsy, well, safety is one concern, right? So we can educate them to change position slowly, sit before you stand, do not take it with anything else, which is going to suppress their CNS, going to make them more slow, sleepy, drowsy, dry. Do not engage in any activity which requires you to be alert, that kind of stuff. And because it's going to make them dry, well, we're going to give them a solution to keep them wet. Well, don't tell them that, yeah, just stand here. I'm going to fill a bucket of water and just kind of drop on your head, right? Not that kind of wet. So more fluids, more fiber. That's what we need to educate them about. So these drugs, they inhibit the action of acetylcholine at muscarinic or the nicotinic receptors. Okay. So the drugs could be muscarinic antagonist or nicotinic antagonist based on whatever the receptor is targeting. Okay. Now, for example, your muscarinic antagonist, such as your atropine, ipratropium. Okay. Ipratropium is used for bronchodilation. Oxybutynin, that is used for overactive bladder. Scopolamine, which is your transderm scope, a little tiny one, a round patch, goes right behind the ear for motion sickness, as well as for post-operative nausea. It's applied before they go to surgery. The nicotinic antagonists, so they block the nicotinic receptor, and they, for example, your succinylcholine, which is a neuromuscular blocking agent used during the surgery to cause muscle paralysis so that it doesn't cause any trauma. Okay. So let's talk about the most common things or most important things. So mechanism of action, once again, anticholinergic. They block the cholinergic receptor. So in this case, the acetylcholine is going to go down. Okay. On cardiovascular, small doses can decrease the heart rate, but the large dose can increase the heart rate as well. CNS, I would recommend just remembering that slow, sleepy, drowsy, dry part. As far as eyes, okay, eyes on eyes, it causes dilation on people, right? And the GI slows down the GI motility. Genitourinary, it causes retention. Somebody has BPH, if you give them Benadryl, well, they're going to retain more urine, and that could be a problem for them. And the eyes also, it's not only going to cause dryness for your glaucoma patients, they will have increased intraocular pressure. Okay, and decreased secretions, dry, saliva, sweat, tears, everything is going to go dry. And respiratory system, once again, it makes your patient slow, sleepy, drowsy, and dry. So respiratory secretions will dry out as well. A good common example will be, once again, the transderm scope, the patch, and also some other drugs used in patients very commonly, hospice patients, okay? Because when patient in hospice, they're lying down in bed. They're old, maybe some had terminal illness. A very common problem with them is respiratory issues and lung infections. So the secretions makes it hard for them to breathe, and the family around them, even they go through a hard time because when they see them labored breathing, hard time breathing, I mean, that bothers them. It's hard to see that. So these medications can dry out the secretions and make it a little easy for them to breathe. Okay. Any questions so far, guys?
No question.
Okay. Let's move on then. Now, some of them you may see not exactly for Parkinson's disease itself, but it actually helps in managing some EPS, extrapyramidal symptoms, unwanted effects comes along with Parkinson's disease drugs. Okay, so it can help manage those symptoms as well. So preoperative, these drugs can give and to reduce the saliva as well as the respiratory secretions. Also, nausea, vomiting, motion sickness, and I said like respiratory because it reduces the secretions. Okay, I'm not worried about that part much. Okay, now because we know it makes your patient dry, well, any condition where your patient is experiencing increased secretions, these drugs can help. Either it's from mouth, nose, wherever it is. These drugs can dry out, reduce those secretions, and help them breathe better. And they also relax and also dilate the airway, making easier for the patient to breathe. So a better bronchodilator property as well. Now, specifically, the drugs which falls under this class, and they are used as an anticholinergic for COPD. COPD. It is ipratropium and tiotropium. They're two drugs. Ipratropium and tiotropium. That's your brand name, Atrovent and Spiriva. Anybody heard about that? Those inhalers? Atrovent, which is ipratropium, and Spiriva brand, which is generic tiotropium. These are inhalers for use in COPD. They are anticholinergics. Reduce the secretions as well as causes bronchodilation. Help them breathe better. Okay. So these drugs can be given, as I just mentioned, that ipratropium and tiotropium. For asthma, COPD, also like exercise-induced bronchospasm. Now, these drugs comes individually as well as some inhalers, which comes in combination with other drugs. Okay, there's aclidinium, omeclidinium, comes in combination as well, and in different formulations, such as like Spiriva, then there's Spiriva HandiHaler, different formulations. And the GI as well, it slows down or decrease the secretions, decrease the motility. A common drug used is, excuse me, dicyclomine, brand name Bentil, dicyclomine. Anybody heard about that drug or what it's used for? Okay, what it's used for?
I don't know what it's used for, but I work in a pharmacy, so I heard about a lot of these drugs.
Oh, you work at
Helps
pharmacy?
with
Oh, I'm sorry, what was that?
it helps with something with the stomach.
Yeah, intestinal spasm. Carly, you work at pharmacy? What do you do there?
I mix drugs for cancer patients, but I worked in a hospital and everywhere.
Okay, but are you technician, pharmacy
Yeah, I'm
technician?
a technician, infusion technician.
Oh, okay, good, all right.
Is this the one that's usually like for IBS?
Yeah, so here it's, like when they have some sort of irritation going on with the, with the bowel, like irritable bowel syndrome, right? Irritable bowel syndrome.
Yes.
So it gets irritated. So you need to kind of slow it down. So it relieves those symptoms when the patient is experiencing those intestinal spasm, especially in case of that IBS, the irritable bowel syndrome. So it's called dicyclomine bentyl. Okay. And then there's another one, it's called Cymex hyoscyamine. Yeah, this is what we just talked about, irritable bowel syndrome. In genitourinary, for urinary bladder issues, so it reflexes the neurogenic bladder as well as an incontinence. Now, what is neurogenic bladder? The nerve which carry messages back and forth between the bladder and the spinal cord. Remember, all messages, signals going through spinal cord. So between bladder and spinal cord, and then going to the brain, they don't work the way they should. So damage, any changes in the nervous system, or infection can cause neurogenic bladder. So the messages are now going back and forth and are not able to take action or react. So when these neurological conditions affect the bladder, that's when we call the bladder is neurogenic. Two types of problem exist. Either it's too active or it's less active. Correct? If it's too active, it's called overactive bladder, right? Or spastic. If it's less, it's called underactive or flaccid. In incontinence means when there's a lack of voluntary control over urination and defecation. Now, contraindication. Remember, it's an anticholinergic. Any condition when patient experience those slow, sleepy, drowsy, dry sort of things, this can make it worse. So glaucoma, increased intraocular pressure, these drugs can increase it. So that is risk, should not be taken. It's a contraindication. Anybody experiencing an acute asthma attack, it's not for like epitropium, tiotropium, that's for management, not for acute control. Then myasthenia gravis, it makes more hard for them to use their muscles. Okay, and somebody who is experiencing the genital, urinary, or GI gastrointestinal symptoms, somebody has constipation, it's going to get worse. Somebody has BPH, increased urinary retention, it's going to get worse. So those are contraindications. Okay. I'm not much worried about it, but here cardiovascular can increase the heart rate. But more I'm concerned about is slow, sleepy, drowsy, dry, along with the solution for that. Okay. So can cause dilation of pupil. Okay. For if it's an eye ophthalmic product, can cause blurry vision for some time. And once again, it's going to make everything dry, including the GI. The motility slow can cause constipation and more urinary retention in the bladder. So somebody already experiencing those issues, that's a no, 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 and no. All right, toxicity. What if patient experienced toxicity from anticholinergic? Well, important drug is physostigmine. Physostigmine is the antidote. For example, somebody has overdose of atropine. They're experiencing delirium, agitation. They could cause injury to themselves. That's when this physostigmine comes handy. Okay. Interactions. Well, interaction could be with anything which extend their effect, make it worse for patient. Anything makes them more slow, sleepy, dry. That is a problem, right? Any other antihistamine, anticholinergic, tricyclic antidepressant, they're going to cause an additive effect. So those are potential issues. As far as your atropine now, atropine. Well, atropine is used in emergency situation when your heart is beating too slow. For example, somebody got in contact with an experiencing toxicity due to insecticide, pesticide, or nerve gas poison. That's when this drug can be used. Okay? And any overdose of cholinergic drugs, mushroom poisoning, atropine can be given, which is a muscarinic antagonist, or you can say anticholinergic, which blocks the effect of acetylcholine. Okay. This drug is also very important, oxybutynin. This is used for overactive bladder. Very common females with overactive bladder. This drug comes in various formulations, okay, different formulations. So it is also an anticholinergic for used for overactive bladder. How? It relaxes the bladder smooth muscle. So the patient who are experiencing issues that they have to go to the bathroom frequently, urgency, incontinence. So this can help managing those symptoms. Okay. Mostly used for overactive bladder and urge continence. What are the adverse effects? Once again, slow, sleepy, drowsy, dry. It's there. That's what it's going to cause. And somebody, with once again closed angle glaucoma, which is high risk. It's a big no-no. It's contraindicated, and anybody had any history of closed angle glaucoma, not the open, closed angle, should not be given. And glaucoma itself, even it's open, it can be given, but you have to be cautious. It can increase the intraocular pressure. Okay. Any questions so far?
Would you ever use this medication, oxybutynin, with someone with an indwelling catheter? And if so, why?
Indwelling catheter? No,
like
that's
a suprapubic or like a suprapubic catheter. Would you use this medication? I've seen it before, so I was just wondering what the indication would be.
Things can be used again to kind of support whatever they're trying to achieve with the catheter, but again, that's not something I would say that first line, or I would say recommended. But again, can be, yes.
Okay.
Okay. Now, next drug is also very important, guys. Scopolamine, and brand name, it comes as Transderm Scope. Comes in a little box, and they're individually packed patches, little tiny round patches. So what is important about this drug is, number one, what it's used for. And the answer is for motion sickness. Motion sickness, people traveling, and they get nauseated, start throwing up, especially on the cruise, seasickness, all that. That is commonly used for. Okay. Number two, when should they apply it? Like, for it to be effective? About 4 to 5 hours before the travel starts, so that it builds up in the system and they do not experience those motion sickness symptoms. Okay.
Sorry, Professor, what was the time you said? How many hours?
4 to 5 hours before the travel. Now, the class it belongs to, once again, it's an anticholinergic, and the adverse effect will be slow, sleepy, drowsy, dry. So safety again, that is also concerned here. More fluid fiber, that should be part of teaching. And now suppose a 70-year, 75-year-old lady came to you, and the prescription you got for this transderm scope, and you just started talking and you said, yeah, I'm going on a cruise, right? And that's why I need it. Go fine. And you just started telling, it can make you slow, sleepy, drowsy, dry. So make sure you do not consume anything else which will make you slow, sleepy, drowsy, dry, right? Now, well, she said, hey, look, I'm going on a cruise, right? Well, I'm not going to do anything else, but I'm going to drink alcohol. Well, alcohol is going to do what? Same thing, right? It's going to suppress their CNS. That is a problem. The lady may not like you, but well, that's the truth. That's a fact, right? Lady might leave yelling at you, oh my goodness, this nurse. Oh, I haven't even started my journey. Already my mood is upset, right? Well, important is how to keep your patients safe. So next important thing is how long this patch is good for. This patch is good for 3 days, 72 hours. Application behind the ear only. Don't put it anywhere else. And more effective here and also less interruptions or anything. 3 days. Now, what if after 3 days, while the journey still continues? Well, it's a 10-day cruise. Well, they can apply a new one on the other side after removing the previous one. Not two patches together. Remove the old one just with simple water and gentle soap, and then pat dry, and then apply on the other side. Once again, good for 3 more days. Okay. And now, contraindication, same as of the whole class. Somebody has glaucoma. It will increase the intraocular pressure. So the simple answer is NO. No, we cannot give it to them. Somebody has urinary retention. Once again, another no. So you need to know, not NO, means KNOW. No, that which patients might be at a high risk if we give this drug to them. Another use. Anybody going for surgery or a woman going for a C-section to deliver a baby. Once again, it's a surgery. In surgery, you will have pain medications given and anesthesia common. And both of them cause nausea, vomiting. And somebody just getting out from surgery, on their tummy, they have the sutures. And if they start throwing up, ooh, 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 not something ideal. So that's where you can also use this drug. Another use, as I mentioned previously, your hospice patient. So when they're on bed, very, 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 very common respiratory issues, pneumonia, all that, and then lungs are not able to breathe well. So much fluid buildup in order to dry the secretions in the respiratory system, in the airways. This can be applied. Keeps the secretion dried out and they are able to breathe better. Okay. Any questions so far?